Hello friends, today we will look at a few more concepts of pediatric emergency medicine that may get tested on your board exams. This would be part 4 of the PEM series and is applicable for both your MRCEM and the FRCEM exams. Without wasting further time, let us now look at question number 16. So a 2-year-old girl is brought in with drowsiness for an hour. She was reportedly at a children's party where she had slush puppies about 90 minutes ago. Soon, she complained about being tired, turning grey and drowsy. Based on your assessment, she is only arousable to pain. What is the underlying reason for her presentation? Abnormal cardiac conduction, drink was spiked, increased glucose catabolism, inhibition of gluconeogenesis, undiagnosed metabolic condition. Recently, RCEM has released the slush intake safety flash. You need to know about it, that these children, when they have slush puppies, they within couple of hours to few hours they can become unwell. So pause the video over here and make your answer choice. So the correct answer here is they come in drowsy because of inhibition of gluconeogenesis. If you look at the safety flash, it is clearly mentioned about the inhibition of gluconeogenesis. A hypothetical 5-year-old child is brought in with burns to both his lower limbs up to the groin. The burns are partial and deep thickness combined and are circumferential. The fluid is calculated using the APLS guide's modified Parkland's formula. Using Broslow's tape, the weight is estimated to be 20 kilograms. So you're going to give Hartmann's solution. This is recommended. But how much should be given per hour after 8 hours of injury? You can pause the video and do your calculation and we'll take it further. So the right answer over here is 53 ml per hour. So if you see the modified Parkland's formula and the rule of 9, modified rule of 9 states that patient's weight, each limb, lower limb is 14%. So both the lower limbs is 28%, and rather than using 4 ml per kg, we are going to use 3 ml per kg, okay, times the weight, which comes around 1680, half of which to be given in the first 8 hours. They are not asking that, they are asking to be given in the next 16 hours. So 840 in 16 hours, if you divide 840 by 16, it comes to 53 ml per hour. That's the modified rule of 9 for pediatric age group and modified Parkland's formula. And remember, Hartmann's is preferred. What burns need to be discussed with or referred to the British Burns Association or Burn Center? So referral is more than 2% total body surface in pediatric and more than 3% in adults. Full thickness, circumferential, non-healing, and suspicion of NAI. So full thickness, circumferential, non-healing, NAI times percentage. The others that have to be discussed, not definitely referral, but discussed, is any burns to hand, feet, face, perineum, genitalia, chemical electrical friction burn, cold burns, unwell child, or child with comorbidities. So these need to be discussed. A 3-year-old is in the emergency, not moving her left upper limb after some injury sustained while lifting the child. The child appears stable and pain-free until you start examining her. You consider a diagnosis of nursemaid elbow. What is the safest and effective management for the diagnosis? Analgesia and splint, hyperpronation, supination and flexion, traction, counter-traction, X-ray, and then manipulation. So take a pause and make your answer choice. So pulled elbow can be reduced by 2 methods. One is supination and flexion, which is very commonly used, and the other is hyperpronation. But the safest and effective management for pulled elbow is hyperpronation. It is more effective than supination and flexion. So the right choice is answer B. Let's look at 19. You are caring for a 3-year-old with a fever and would want to seek further information about managing fever in pediatric population. Your consultant asked you to refer to the traffic light system as given by NICE guidance. The traffic light system in fever is recommended for up to what age group? Is it for all pediatric patients? Is it only for less than 1 year, less than 3 years, less than 5 years, or less than 6 years? Take a pause. This is either you know or you don't know question, and then we'll look at the right choice. So the right answer over here is option number D, less than 5 years. So if you look at the traffic light system, it looks like that: green, amber, and red. How do you remember it? Remember chart, color, hydration, which is circulation, activity, respiration, and T is for temperature or others. Okay. And then you can make up your mnemonic or way to remember this traffic light system. Last question for the day. 15-year-old patient is in the department with DKA. The weight is calculated to be 96 kilogram. The calculated maintenance fluid per hour would be. So here there is a lot of calculation to be done. I don't think so this question should be asked, but you need to know how to do it. So all patients with fluid deficit will need a 10 ml bolus over 30 minutes. All patients will come in with DKA will need 10 ml per kg bolus over 30 minutes. And this has to be subtracted from the deficit fluid. Now the definition has become very easy. There is mild, moderate, and severe. Mild and moderate is assumed to be 5% dehydration, and severe is assumed to be 10% dehydration. So they are asking maintenance fluid, not the deficit fluid. So we'll just look at the maintenance fluid. The maintenance fluid is calculated by using Holliday-Sager formula: 100 ml per kg for the first 10 kilograms, 50 ml for the next 10 kilograms, and then 20 ml per kg. But here is the catch. The weight here is saying 96 kilogram. We are not allowed to calculate up to 96. The maximum weight for DKA management would be 75 kilogram. So we'll take into consideration 75 kilogram. Okay. So 1 liter for the first 10 kgs, half a liter for the next 10 kgs, and then we have 55 into 20, which is 1.1. Right answer over here is 115 ml per kg per hour. It's unlikely to be asked, but a few things to remember in DKA is mild, moderate is 5% dehydration, severe is 10% dehydration. If they are on a continuous pump, that pump has to be stopped. If they are on long-acting insulin, that has to be continued. Insulin should be started after the fluid bolus. Otherwise, there has been risk of cerebral edema developing. Insulin should be started at 0.1 unit per kg per hour. And children less than 5 years of age, you will consider going half the dose of insulin. That is 0.05 units per kg per hour. That's all for today. We'll look at some more questions in video number 5, which I'll release soon. Till then, happy studying. Consider subscribing to this channel, and thank you for watching this video. If you like this series, please consider joining the membership of the channel. I hope you are doing well. Study well. Peace.